morning, respected madam and all my dear friends. My today's topic is shoulder pain. Shoulder pain is the causes of it is the third leading cause for patients seeking musculoskeletal care. The causes in brief we will see non-traumatic and traumatic. Non-traumatic are intrinsic, which are glenohumeral and extraglenohumeral. Glenohumeral comes rotator cuff tendinopathy tear, glenohumeral arthritis or instability, subacromial bursitis, labral tear, and adhesive capsulitis. Extraglenohumeral causes are acromioclavicular arthritis, subacromial impingement, suprascapular bursitis, and biceps tendinitis. Extrinsic causes are disc herniation, canal stenosis, post-herpetic neuralgia, complex regional pain syndrome, long thoracic and suprascapular neuralgia, and referred pain, myofascial pain syndrome, diaphragm irritation, myocardial infarction, intrathoracic tumors, brachial plexopathy, and fibromyalgia. Traumatic causes are related to all injuries, acute known injury or chronic unknown injury, proximal bicep tendon tear, labral tear, AC ligament sprain, muscle sprain, shoulder dislocation, etc. Systemic causes are all autoimmune disorders like rheumatoid arthritis, and collagen vascular diseases. So this was in short about the distinct causes. Now we will see differentiating points of inflammatory arthritis versus degenerative arthritis. Inflammatory arthritis is common in the young peoples, while degenerative in the old peoples. Inflammatory arthritis where pain increases on rest and decreases with activity, and degenerative arthritis it is reversible, decreases on rest and increases with activity. Morning stiffness is more than 30 minutes to 1 hour in inflammatory arthritis, and it is less than 30 minutes to 1 hour in degenerative arthritis. Now, whenever patient comes to us, we are going to take his detailed history and for the pain assessment. So here is a easy to remember mnemonic: Ola-car nitride. OM is onset, LA location, C character, aggravating factor is A, R relieving factor, night is night pain, and rider is a radiating site of the pain. Now, age also, if there is an instability, it is more common in less than 35 years of age. Rotator cuff and glenohumeral pathologies are more common in 35 years of age. We have to look after occupation, hand dominance, comfortable preferred limb position, and any trauma related history. Now this is the these are the location of the pain. According to the pain site, we can see the pathologies. These are the common pathologies which can happen with the pain site. This thing: front and outer aspect of joint, middle of the arm, glenohumeral joint and rotatory cuff pathologies. Enterolateral shoulder pain is associated with impingement and tendinopathy. Top of the shoulder is the AC joint referred pain. Posterior shoulder pain, teres minor and infraspinatus, those are the back muscles. Poorly localized are the referred pain. And this is like movements that causes pain and their pathologies. Lateral rotation is painful lateral rotation is associated with anterior dislocation. Night and resting pain is bony injuries or malignancy. Sometimes rotator cuff tear also present as a night and resting pain. Activity related pain, tendinitis. Pain greater than 90 degrees of abduction AC joint. Aggravating factors are overhead elevation and impingement and relieving factors. Now, we can see in short about shoulder movements and their muscles and nerve supplies, which in short about flexion, extension, abduction, adduction. Flexion is by anterior fibers of the deltoid and pectoralis major. Extension with posterior fibers of the deltoid and latissimus dorsi. Abduction with supraspinatus initial 15 degrees and middle fibers of the deltoid from 15 to 90 degrees and trapezius above 90 degrees, that is overhead abduction. Adduction, pectoralis major and latissimus dorsi. Now lateral or external rotators are infraspinatus, teres minor, posterior fibers of deltoid. Internal rotators are subscapularis, anterior fibers of the deltoid, latissimus dorsi and pectoralis major. Now supply is suprascapular, axillary, lateral pectoral. These are the basic shoulder movements, which you can see in a pictorial diagram. Flexion, extension, abduction, adduction, and medial and lateral rotation. Now, these are the scapular movements and their muscles involved. Scapular elevation by levator scapulae, upper trapezius, depression by lower trapezius, retraction by lomboids, major and minor, and protraction by serratus anterior. Now, any indication of muscle spasm, deformity, wasting, all these things we have to look for. Bruising, swelling, paresthesia or numbness, heaviness and weakness of the limb after activity, stiffness, severe or progressive in the frozen shoulder. Any indication of nerve injury like paresthesia, numbness, weakness, activities, impaired activities, past history of pain, surgery, and all the comorbidities like diabetes, stroke, cancer, IST, GI pathology, or this thing. Then we have to examine the patient. To start with inspection, this we have to remember that we have to always compare with normal shoulder. Examine from front, side, back, behind, and above, and both the upper limbs, neck, upper chest, and outline of the scapula must be visible. Now, these are some deformities on inspection. You can see. Sorry. Step deformity, distal end of the clavicle line superior over the acromion process, and sulcus sign also you can see, sulcus below acromion, and flattening of the deltoid muscle, that is associated with anterior dislocation of the glenohumeral joint or deltoid paralysis. Now, this is the examination of bony contours and alignment. Atrophy, like so upper trapezius, supra and infraspinatus atrophy. Supra and infraspinatus atrophy can occur in cases of suprascapular nerve impingement in the notch or further below. Winging of the scapula, medial border moves away from posterior chest wall. The winging can be static, dynamic, or springless deformity. Static winging at rest due to structural deformity itself, and dynamic winging with movements caused by lesion in long thoracic nerve and spinal accessory nerve. And this springless deformity is congenitally high or undescended scapula. Now, these are the various range of motions observed from front and behind and patients with either standing or sitting position. These are the active range of movements: abduction 0 to 180 degrees, adduction 0 to 50, flexion 0 to 180, and extension 0 to 60. External rotation in extension 0 to 70 degrees and abduction 0 to 100 degrees. Internal rotation in extension 0 to 70 and abduction in 0 to 70 degrees. This you will remember once you, it will take time. Now, range of passive range of movements are examiner press firmly down on the top of the shoulder with one hand, while the other hand moves the patient's arm. You have to look for power, muscle strength, supraspinal, and there are various tests for each and every muscles, like supraspinatus empty can's test, subscapularis belly press test, and infraspinatus teres minor. Patient's arm by the side with elbow flexed 90 degrees. Patient is asked to externally rotate the arm against examiner's hand on the side of the arm. These are the examples of various tests. Now, in short about the special tests and in the special situations, like impingement test are knees, Hawkins, Kennedy test, rotator cuff tears, drop arms test, external rotation, lag sign, shoulder instability, apprehension, relocation, anterior release test, AC joint pathology, O'Brien's test, AC joint tenderness test, bicipital tendinitis, speed test, and Egerton's test. We will go through this test later on. This is in short about the shoulder joint. In brief, we will see the anatomy of the shoulder joint. As we know that this is the ball and socket joint, and which gives giving a joint, this head of the humerus is larger than the glenoid fossa, so which giving the joint a wide range of movement at the cost of inherent instability. So there are various structures which providing stability to the shoulder joint. Those are like glenoid labrum. Glenoid fossa is deepened by a fibrocartilaginous rim to reduce. This is the labrum. To reduce the disproportionate of the surfaces. This is the shoulder joint. These are the bursae. Like there are 5 main bursae: subacromial, subdeltoid bursa, which is commonly getting affected. Subscapular recess, subcoracoid bursa, Brachoclavicular bursa and supraacromial bursa. What is bursae does whenever subacromial they are located deep to the subacromial bursa, located deep to the deltoid and acromion, superficial to the supraspinatus tendon and joint capsule, and it reduces the friction beneath the deltoid, promoting free motion of the rotator cuff tendons. So and these are the now after bursa, these are the various ligaments. So these are the 5 ligaments where you can see this is the coracoid process, this is the clavicle, acromion, and this is the humerus. So coracoid process to acromion is a coracoclavicular coracoid process to clavicle is the coracoclavicular ligament. These are the coracoacromial ligament, coracohumeral ligament, and this is the transverse humeral ligament, which you can see over here, glenohumeral ligament. Acha, okay. Okay. Then this is also a picture of this thing. These are the ligaments. There are also the ligaments. This is the supraspinatus tendons with the UHG picture. Supraspinatus tendon. This is where subdeltoid bursa is here, and this is the myotendinous junction, humeral head, greater tuberosity, and this is the upper one is the deltoid muscle. Now there are many muscles which acts on the shoulder joint, attaches the shoulder joint, which attaches the upper limb to the axial skeleton of the trunk. Pectoralis major minor, subclavius, serratus anterior attaches the upper extremity to the clavicle and the thoracic cage. Posteriorly, scapulohumeral muscles are extrinsic, intrinsic. Extrinsic are all the back muscles, trapezius, latissimus dorsi, levator scapulae, rhomboid major minor. Intrinsic muscles are deltoid, teres major, rotator cuff muscles. Supraspinatus, rotator cuff muscles are the one which are more significant to us. Those are supraspinatus, infraspinatus, teres minor, and subscapularis. Now this is the picture of rotator cuff muscles, which are the stabilizer, and they steer the humeral head within the glenoid cavity during various movement of the upper limb. Supraspinatus, which abducts the arm from the 0 to 15 degrees, infraspinatus, external rotation, teres minor, external rotation, and subscapular is also internal rotation. So now this is the supraspinatus. We will go in short when this thing is there. So this is supraspinatus and infraspinatus. As per the namesake, they are the origin is from the same. This is the first block is the origin, second is the insertion, third is the action, and fourth is the supplying now. So this supraspinatus and origin is the supraspinatus fossa, and they insert on the greater tubercle. So remember, supraspinatus, infraspinatus, and teres minor, they insert on the greater tubercle on the superior, middle, and inferior facet. Okay, and then supraspinatus, infraspinatus have suprascapular now is the supply, and supraspinatus does abduction. Just now we saw the 0 to 15 degrees. Then infraspinatus causes lateral rotation along with teres minor. Subscapularis in the subscapular fossa origin, and it inserts in the lesser tubercle. So only one muscle inserts on the lesser tubercle, and its action is medial rotation and supplied by subscapular now. Now this is very important muscle, so trapezius muscle, which is a diamond shaped, and it is originates from the medial third of the superior nuchal line, external occipital protuberance. It has 3 parts. Like superior part is descending, superior fibers are descending, middle are horizontal fibers, and ascending fibers are the inferior part. So superior part is the originates from the occipital protuberance, medial third of the superior nuchal line, nuchal ligament, and the spinous process of the C1 to C6 vertebrae. The insertion on the lateral border of the clavicle. Middle horizontal fibers originates from the spinous process of the T1 to T4 vertebrae, and insertion on the superior crest of the scapula, spine of the scapula. Inferior ascending fibers, they originates from the T4 to T12. So C1 to C6, then T1 to T4, and then T4 to T12. And then they ascending fibers, inferior fibers, they inserts on the medial end of the scapular line. And their action is the elevation, rotation, retraction, and depression of the scapula. Now supplied by accessory nerve and spinal nerves, C3, C4. Now these are some trigger points where we have to address during our Botox or dry needling. Now this is also one of the strongest muscle, deltoid muscle, and it has origin from the clavicle, acromion, and spine of the scapula. Middle fibers does abduction from 15 degrees to 90 degrees. Anterior fibers, they cause flexion and internal rotation, and posterior fibers extension and external rotation. Serratus anterior is also called as a boxer's muscle, fan-shaped muscle at the lateral wall of the thorax, originates from the first to 8th or 9th ribs, and insertion on the anterior surface of the medial border of the scapula. Now innervated by long thoracic nerve, and action is to draws the scapula anterolaterally. It also rotates scapula, draws inferiorly and laterally, and suspends scapula on the thoracic wall. Rhomboids. Rhomboids are the two muscles are the rhomboids. Rhomboid minor is above and major is below. So minor is attached to the nuchal ligament, spinous process of the C7 and T1, and major T1 to T4. And minor is inserted at the root of the spine of the, this is the spine of the scapula. Minor is inserted at the root of the scapula, and major is inserted on the medial border of the scapula. And innervated by dorsal scapular nerve, they rotates the glenoid cavity inferiorly, draws scapula superomedially, and supports position of the scapula. Levator scapulae is also a very important muscle. So main function is the elevation of the scapula. Levator scapulae acts with the trapezius, latissimus dorsi, rhomboids, pectoralis major, and all these muscles. Along with that, they inferiorly rotate the glenoid cavity, stabilize the spine, and extend and laterally flex the neck. So the levator scapulae, the origin is from the C1 to C4 transverse process, and insertion on the superior angle of the scapula. C1 to C4 transverse process and inserted on the superior angle of the scapula, supplied by dorsal scapular, and action is the scapular elevation and downward rotation. So these are the action of the levator scapulae. The synergist muscles to the levator scapulae are the rhomboids major, minor, and the trapezius. Now latissimus dorsi. It is also a very big muscle, origin from the vertebral part, like spinous process of the T7 to T12, and thoracolumbar fascia. Iliac part, posterior third of the crest of the ilium, and on the 9th to 12th ribs. So scapular part at the inferior angle of the scapula, and inserted into the intertubercle circles of the humerus between, that is also called as lady between two majors, that is pectoralis major and teres major. Now innervated by thoracodorsal nerve, C6 to C8. Action is arm internal rotation, adduction, and extension. This is the bicep brachia. Act on both on the shoulder joint and elbow joint. Short head, apex of the coracoid process, originates from the apex of the coracoid process, and long head on the supraglenoid tubercle of the scapula. Insertion on the radial tuberosity of the radius. And action is the weak flexor of the arm at the glenohumeral joint, and flexion and supination of the forearm at the elbow joint. Now these are the pectoral major and minor muscles. Pectoralis major has three heads of origins: clavicular, then sternocostal, and abdominal. Insertion on the crest of the greater tubercle of the humerus, and innervated by lateral and medial pectoral nerves. Action is the adduction and internal rotation of the arm. Pectoralis minor underneath the pectoralis major muscle, origin from the rib cartilages of the third and fourth, and insertion on the medial border of the coracoid process. It is innervated by medial pectoral nerve. Action is the draws the scapula entero-inferiorly. These are various movements of the shoulder joint. Now we will come to the common shoulder conditions. Now, chronic, as we all know that chronic pain disorders are associated with 95% patients are associated with myofascial component, which is the major component in the shoulder pain also. So subacromial impingement is the commonest pathology, which is the painful situation which we are dealing with. So that's 44.66%, adhesive capsulitis 12%, bicipital tendinitis 4%, AC joint osteoarthritis 7%, and others are instability and infection are 7%. Now this is the first this thing, subacromial impingement. Usually commonest in the femurs thrower. Subacromial space pathologies, partial thickness, rotator cuff tears, rotator cuff tendinosis, calcific tendinosis, and subacromial bursitis. But why did this impingement occurs? This occurs when the tendons of the rotator cuff muscles, this is the acromion and this is the supraspinatus tendon, which is going below the acromion. So these tendons of the rotator cuff muscles become irritated and inflamed as they pass through the subacromial space due to subacromial spurs, thickening or calcification of the coracoacromial ligament and inflammation of the subacromial bursa. This is the Neer's test, which is for the impingement, positive forward elevation of the arm in the fixed scapula. We will see it later on. Neer has described 3 stages of impingement, 1, 2, 3. Stage 1 is usually we see in age less than 25 years, where edema and hemorrhage of the subacromial bursa and cuff is there. Stage 2, age 25 to 40 years, irreversible damage, such as fibrosis and tendinitis of the rotator cuff. And stage 3, with the more than 40 years of patients, more chronic changes happen, such as partial or complete tears of the rotator cuff. Now this is the shoulder impingement, where you can see this is the normal shoulder, and you can see the reduced subacromial space because of the bursitis. Now how to go ahead with the shoulder subacromial impingement, like these are the investigations: X-ray, 3-4 views of the shoulder joint, like AP internal in internal and external rotation, axillary scapular Y view. Usually they X-ray usually normal. Then neck X-ray also we should do, MRI, and treatment is a standard treatment like physiotherapy, and with all the maintaining range of movements and improving posture, strengthens and stretching, pain medications, NSAIDs, neuromodulators, plus or minus neuromodulators, narcotics and ice packs, subacromial steroid injection to improve tolerance for rehabilitation, subacromial, and then if all the other conservative treatment fails, then subacromial decompression and bursectomy is the last option. Now these are some pathologies. You can see the tear of the rotator cuff muscle, that is supraspinatus tear. You can see in between, you can see the normal shoulder, and here also you can see the inflamed muscle tendon. These are also some related pathologies. You can see the normal joint and adhesive capsulitis, along with other. Now these are some UHE pics of bicep tendon in the bicipital groove, and this is the AC joint, and yeah, this is the deltoid muscle, and this is the pic of one of my lecturer who came to me for her shoulder, and she was having mainly trapezitis since 4 years, and this is the needle you can see from the trapezius and levator scapulae. She got relieved in 4 to 5 sessions. This is also these are the trigger points of the shoulder joint muscles, and this also you can see the trapezius, supraspinatus, rhomboid also you can see, and infraspinatus. Now we have to rule out some red flag signs: tumor, acute rotator cuff tear, dislocation, infection, unexplained sensory and motor deficits, pulmonary vascular compromise. You can see the labral tear. These are the various movements. Now rotator cuff tear. Now maybe a history of fall on outstretched arm. They are acute and chronic. Acute, as we all know, that it is less than or equal to 2 to 3 months. Chronic, more than 3 months. Tear can be a full thickness tear. Full thickness tear again divided into partial or complete tear, and there is a massive tear also. A massive tear means that will be associated with tear of other rotator cuff muscles. Now there will be limited range of movements, weakness more than pain, but normal passive range of movement. Supraspinatus is the commonly affected 70% of the rotator cuff tear, and these are the tests: weak empty can 30 degrees and drop arm test. Infraspinatus 20% of the rotator cuff tear, weak external rotation and lag sign. Subscapular is less than 1% and weak internal rotation and belly press test. This is so you can see the full thickness tear in the supraspinatus. Now, bicipital bicep tendinopathy, where pain radiates from anterior shoulder to anterior brachium, pain with bicep flexion, especially with supinated wrist, usually insidious, sudden onset. Examination: tenderness overlying proximal bicep tendon at bicipital groove, pain with extension of the shoulder. The umbrella term for bicep injuries that include tendinitis means inflamed tendon, tendinosis means non-inflamed degenerative tendon, and tenosynovitis means inflamed tendon sheath, and ruptured bicep tendon secondary to degeneration or tear. Now, bicep, usually not a primary pain generator, occurs in association with underlying shoulder problems. So these are the speed test and Egerton's test, where registered shoulder flexion with wrist supinated and elbow extended, and Egerton's test is registered wrist supination with elbow at 60 to 90 degrees. So both these tests are they are doing. Now, investigations and treatment is common in all of the pain conditions like X-ray, MSK, USG, and NSAIDs physiotherapy, eccentric bicep exercises, tendon sheath, PRP, or steroid injection. And if any conservative treatment fails, then the patient goes for surgical management. AC joint pain, tenderness, swelling at the AC joint, pain with cross-arm adduction, test, downward traction, secondary impingement signs, limited positive IR, pain with internal rotation pain with Niels and Hawkins test, X-ray, MRI. Then here also you can give NSAIDs, ice pack hit, AC joint steroid injection, physiotherapy, and if everything fails, then distal clavicle excision. These are the routine management of the pain conditions at the shoulder joint. Now, AC joint sprain, you can see the normal shoulder joint where you can see acromioclavicular ligament intact, and here you can see little damage, and here you can see the rupture of the acromioclavicular ligament. Yeah, this is like imaging, X-ray, and all. This is same treatment for 1 and 2 grade non-operative treatment: sling initially and ice, NSAIDs or narcotics, AC joint steroid injection, physiotherapy, avoid developing impingement. And type 3 non-operative or surgery. If distal clavicle overrides acromion on cross-arm adduction test, then surgery. And type 4 and 6 are for surgery, AC joint reconstruction. Glenohumeral instability, history, subluxation, pop back in without specific treatment, dislocation, someone else reduces or specific technique used to relocate the joint. Now, examinations are arm hanging, limb side at the side, inability to reach across body, inability to externally rotate the arm, anterior instability, apprehension relocation test sensitive, and inferior instability, sulcus or traction test. Then imaging, we have to do all the investigations. And for the dislocated joint, you can reduce dislocated joint intraarticular by giving intraarticular lignocaine or IV under IV sedation, sling and immobilization. But sling versus surgery is the surgery has a success rate of recurrence rate of 47% versus 16%. So surgery is the good option for the instability. Now, the most common is the frozen shoulder, primary frozen shoulder and secondary frozen shoulder with precipitating traumatic event. Now, history, waist pain, pain worse with reaching, progressive loss of motion, internal rotation more than external rotation, more than abduction. motion returns in opposite sequences when they get recovered. Most common in females 40 to 60 years. Autoimmune or chronic inflammatory diabetes with 25% diabetic patients, they are associated with this problem. Hypothyroidism, usually insidious onset. So you can see the three phases of the frozen shoulder: acute, adhesive, acute phase, adhesive, frozen or stiffening phase, and the resolution or thawing phase. Now, acute phase is therefore 2 to 9 months. Shoulder pain at rest with sharp pain at extremes of motions, pain at night with sleep disturbances. Now, adhesive and frozen stiffening phase is 4 to 12 months, and pain subsides at extremes of movement. Resolution and thawing phase 5 to 24 months, progressive improvement in functional range of movements, but 40% persistent symptoms and restriction of movements beyond 3 years, and 15% patients they live with persistent pain and long-term disability. Treatment is education, physiotherapy, NSAIDs, narcotics, intra-articular corticosteroid injection, subacromial, Varsha, glenohumeral joint. Repeat every 4 to 6 weeks if the steroid injection. Suprascapular nerve block, and you can do the manipulation under anesthesia if conservative treatment fails. Now, in short, with summary, the current and new pain treatment modalities: pain medications, painkillers, neuromodulators, opioid, neural interventions like different blocks, suprascapular, dorsal scapular, spinal axillary nerve block, PRP and corticosteroid injection in subacromial, subdeltoid, pulsar injections, joint injections also people are giving, intra-articular, acromioclavicular, glenohumeral, and PRF of the nerves associated. For muscles, only routinely physiotherapy is available, but newer Ashirvas approaches are ultrasonography guided dry needling with or without Botox in the stiff affected joint muscles. Now, I just wanted to show you one of the case which I treated 4 years back. She was our staff nurse, and she had come to our ortho OT, and she was working in ortho, so orthopedicians had already seen her, and there was nil active management from them. It was a severe neck spasm. She came with a very acute pain of 10 out of 10 pain. And that time I was very much new to the dry needling, and I just did her needling, very few needling I did her for her neck spasm, and then she got relieved. After removal of needle, she was okay. She was 90% relieved, and then I started her on pregabalin and our myospas and all. And later on, she told me about her other problems, like her shoulder was involved since 6 years, and she was unable to make chapatis, unable to wear her clothes and all. She was in need of support with the help of her family members. So then I started with her UHDN sessions, and she responded very well to that. Within 3 sessions, I checked her dash score also. It was 78 to start with, and then it was after 4 sessions, her NRS, she was completely pain free, and dash score was 78 to 0, and she's able to do her personal work, household activities, and she meets me somewhere, but she says she's okay. And in February only I took her a review after 4 years, but still she was fine. So this is the little bit about discussion. MPS affects 95% of patients with chronic pain disorders, and UHDN proved to be safe, targeted, instant relief, and muscular intervention. Insertion of needle in myofascial trigger points produces local twitch reflex in muscles. UHDN produces instant pain relief by physical needle effect via LTR. This we all know, but just a summary. Microtrauma from needle insertion releases platelet-rich plasma into damaged muscles, causing a regenerative effect in these muscles, produces relaxation and pain reduction. UHDN targets pain and disability resulting from structural impairment caused by MTRPs in taut band. Taut bands, which mechanically alters the function in all co-working muscles of the shoulder and neck, gives rise to myofascial pain syndrome, results in disabilities. And UHDN reversed pain as well as all disabilities. So this is sister's pre-treatment and post-treatment this thing. So my dear friends, Yeah, this is the you are all welcome to learn the USGTN. In shoulder pain, muscles plays important role. Routine management of pain with medicine, surgery, pain procedures, and physiotherapy. But let us learn new modality of managing shoulder pain, considering neuromyopathy as cause of pain instead only a neuropathy. Because this is safer, effective, instant relief, longer lasting, and economic. It can be used as sole modality or along with routine neural intervention to provide maximum pain relief. And it should be implemented as routine modality of pain management. Let us learn ultrasonographic guided dry needling for all pains. Now these are two last slides of mine. Here actually this is the pic from Ponniyin Selvan 1 movie, but they have shown the 1,000 years back 10th and 11th century Chola Samrajya fictitious story, and who was called by a son of Kaveri also. But that time also it was existed, and I read his whatever that novel 1955 Ramakrishna something, that author's novel also. This is the evolution history. Actually, this slide made by my student during his presentation. This is evolution of dry needling 1904 to 1996. So there are many legends who have evaluated the dry needling, like Kellgren's, then Net Travel, Carl Levitt, etc. But our madam, Dr. Lakshmi Vas, she has invented and in 2003 ultrasonographic guided dry needling and neuropathy as a concept for all pains, and she made the impossible cure of complex regional pain syndrome. Uh, Impossible cure of the complex regional pain syndrome possible. Thank you.